Okay. Okay, right. Okay, can you hear me clearly, children? Yeah, right. So today we are starting the right. So today the request was for us to start infertility, right? And I was just thinking about it. So what we'll do is I will do it in 4 segments. So that normally it's 4 segments. First one is I will give you an overview of female infertility. And then we'll talk about male infertility. Next, we will talk about assisted reproductive techniques. All right. And then fourth, we'll do a short session on unexplained infertility. So those are the 4 main areas that we need to look at when you are thinking about infertility. And also, I have done polycystic ovarian syndrome, which has quite a significant area in infertility as well, right? So therefore, but I have covered that, so you all can basically go through that lecture and see what's happening. Okay, right. Now let's look at an overview of female infertility, which is the first of maybe 4 lectures which I'm going to conduct, right? Now, first of all, if you are looking at infertility, right? Say when a couple comes to you and saying they have a problem with infertility, it is very important for us to initially understand whether there is a problem of infertility or not. Because sometimes the couple will start trying for 1 or 2 months and then come to you saying, I have a problem with infertility. Okay. So all these couples actually we should not treat because they need to come into the definition of infertility initially for us to initiate any form of management, right? So the overall understanding you have to have, children, is that number 1, if a couple starts to try, right, and they have regular intercourse and trying to conceive, around after about 3 months of trying, about 53% of them will conceive in the first 3 months. Okay, if they try on for another 6 months, that is in 6 months, right, 72% of the women couples will conceive, right? At the end of 1 year, 85% will conceive, right? If they have regular unprotected intercourse. So if you start treatment or if you start investigating, right, before 1 year, then probably you're not doing them a good service. Okay, unless of course there are reasons for you to investigate. If they have symptoms, severe dysmenorrhea, dyspareunia, or the male has problems, right? In that case, if there is a problem, and then you might need to investigate those, which may be soon. However, if there are no symptoms from the male side or the female side, and there are no problems, you don't need to start investigate them unnecessarily. So therefore, you have to remember that you can ask them, advise them, and give them the general advice about infertility, and ask them to go and come back in 1 year if they don't conceive. Now, if you leave all these couples alone until the end of the 2nd year, all right, 93% of these couples will conceive, right? However, from the end of 1 year to the end of the 2nd year, From 85%, it goes up to 93%. So basically about 8%, there'll be an 8% increase for one whole year after the first year. You all understand? So therefore, that percentage is not much, because the remaining, from the remaining 15% at the end of 1 year, 50% of the couples, that is about 8% more, will conceive in the second year. While at the end of the second year, if you don't do anything at all, 7% of the couples will remain with fertility problems. Do you all understand? So it is logical for us to start treatment at the end of 1 year, right? Because only another 8% will conceive even if we wait for another 1 more year. Got it? So the normal understanding is that if the couple has been trying for 1 year, right, and they have not conceived, yes, it's better to start treatment. Correct? Second thing is, of course, if the age is, say, more than 35 years in the, or if the patient is having symptoms, right, or the male or the female partner is having problems, then of course treatment can start and investigations can start at any time they come to you. I'm talking about the couples who are not having any problems or not complaining of anything. Is that clear? So do not initiate investigations, right? If the whole couple is asymptomatic, they are having regular sex, the male partner has no problem, female partner has no problem, then of course don't initiate treatment, wait for 1 year, because 85% of the couples will conceive, right? Of course, you have to give them the general advice. What are these general advice? If you want the couple, when they come to you for general advice, what are the things that you are going to tell them? Number one, you can have specific advice. Now, if you look at general advice, right, they can be divided into 2 large groups. The first group is the advice that you give to every couple. All right. And the second is, if the couple, if we discover a problem in the couple initially, right, then of course we might give them more specific advice. Right? Number one, what are the general advice that we want to give a couple who is coming to you and saying, doctor, we are planning to have children, and then we are planning to conceive. Is there any advice that you want to give us, right? Number one, we need to tell them about folic acid. All right, so you tell them about folic acid, and right, okay, so we tell them about folic acid. They need to take 1 milligram. Usually it's 400 micrograms, but we have only 1 milligram tablets in Sri Lanka. 1 milligram at least 3 months prior to the proposed date of conception. Why? It has been found. It's been found by evidence that it reduces neural tube defects. Okay, so we advise them. We also advise them about rubella immunization. Please go and get your rubella, or if you have not had your rubella, then they need to get their rubella, because rubella infection during pregnancy can cause a lot of problems to the baby. A lot of malformations can occur, right? So therefore, you get that. If they do not remember that they are immunized for rubella, right, because it happens normally in the school days, then you can simply do a rubella immunoglobulin G. You can prescribe it, rubella immunoglobulin G, and then check whether they have antibodies for rubella. If it is present, that means either they have been given the injection or immunization, or they have had rubella in their previously, so they are immune. Got it? The third most important thing which you have to tell them about is about the frequency of sexual intercourse. See, now there are 2 ovaries, right? And ovulation can occur at any time throughout the cycle. Of course, it frequently occurs more frequently in the mid-cycle, but ovulation can occur at any time of the cycle. What does that mean? Conception can occur at any time of the cycle. Logically, say when the egg comes out, or ovulation occurs, the tube goes over the ovary, and due to chemotaxis, because there's a chemical change, and the fimbrial end, because it's connected to the fimbrial end is connected to the ovary by another fimbrial, right? It's called fimbrio-ovarica, right? So it understands, okay, there's ovulation occurring, and then it comes over the ovary, and ovulation is preferentially into the tube. It doesn't go around. It goes preferentially into the tube. It's working normally. And then what happens is the egg stays there in a pool, which is created at the fimbrial end with all the nutrients. It swims around, right, and waits for the sperm. It can live there for 48 hours. Once sexual intercourse takes place, the sperms swim up, the good ones, and then they lie swimming around in that pool at the fimbrial end for about 4 to 5 days, sometimes longer. So if the couple has sexual intercourse at least 2 to 3 times a week, there'll be always a constant store of sperm at the end of both tubes, swimming around, waiting for the egg to come out. You all understand? So therefore, the advice that stems from that is that you need to tell them, look, to conceive, it is best if you have sexual intercourse 2 to 3 times a week, right? It has been found that if they start to have a timetable to have intercourse, right, where different methods are used, okay, ovulation kits are used, okay, now ovulation is happening, right? And then all the timetables are about, okay, this is the fertile period. Immediately what happens is there is a stress for the male as well as the female partner to have sexual intercourse, right? And that stress will create non-ovulation, and therefore it is counterproductive for fertility. So it is not advised to have very strict so-called fertile periods. It is not advisable to advise patients about the fertile period, right? And the general advice that should be given is have sexual intercourse 2 to 3 times a week throughout the cycle if you want to conceive. Is that understood? So those are the general advice that you need to give. Of course, if they have medical problems, those need to be controlled, and they should be given adequate contraception until the problem is controlled. There are, of course, certain medical conditions that they cannot conceive, right? Those are, if, for example, if there's a reversal of the shunt, if they have pulmonary hypertension, right, and if there's a reversal of the heart shunt, right, and if they are in renal failure, of course, if they're in renal failure, they will not conceive either. But still, if there are on drugs which are anti-cancer drugs, right, those are embryo toxic, right? So those ones we should advise not to conceive. So that is a different chapter. But generally, for couples who want to conceive, these are the general advices you have to give. And of course, if they have something like polycystic ovarian syndrome, if they are overweight or underweight, right? Underweight also, ovulation does not occur. Overweight also, ovulation will not occur, right? And these ones, so we will have to advise them appropriately, either to gain weight or lose weight. Gaining weight is difficult. Losing weight is also difficult, right? So anyway, we have to advise them appropriately what to do. The next thing is, once we have advised them about all these, so we give them the general advice and then we send them off, right? And then you tell them, okay, look, you have enough one more time. Just go, come back in 1 year's time. You all understand? I'm talking about an asymptomatic couple, right? So remember that data. In 3 months, about 56, 57. In 6 months, about 72%. At the end of 1 year, 85. Without any treatment, they will conceive. And at the end of second year, it's 93%. Only 7% will remain at the end of the second year. Okay? Right. Is that clear? Right. Now, if you look at the general reasons for fertility, 35% will be male infertility. Right? Around 35%, the male has a problem. Now the remaining 65%, about 33%, about half of those 65%, it will be a female factor infertility. Right? So roughly 1/3 male, 1/3 female. The rest of the 65%, that is about half of the 55%, about 32-33%, is inexplained or unexplained infertility. We don't know how to explain it. You all understand? So if there are 100 couples who come with infertility and they fall within our definition of infertility, 35% of the time you will find male factor, right? 65% of the time, the male factor is not there. Out of the 65, half of them will be having a female problem. Okay, so female factor, definitive problem. The rest, or the 50% of the 65%, infertility is not explained, or at least we do not have the technology and the know-how with what we have to find out exactly what is wrong. You all understand? So that is why we group them into unexplained infertility. Got it? So roughly 1/3, 1/3, 1/3. Unexplained 1/3, male 1/3, female 1/3, roughly like that. Got it? So if you are asked for etiology, that is what you have to talk about. Is that clear, children? Right. So that is the rough idea that you have to have about infertility. Okay. Now, if you have an overall look at infertility, okay, what we do is clinically, we go along the pathway of conception as to, first we have to understand simply, it's very simple actually, what are the things that needs to come into play for women or a couple to have a conception, right? Number one, the ovary needs to ovulate, okay? So any factor affecting ovulation can cause infertility in the womb. Okay. Now we are talking about female infertility today. So any factor affecting ovulation, right, can cause infertility in the womb. So in the history also, and in the examination, and in the investigations, and any investigation, we have to look and diagnose and treat an ovulation, or if the ovulation is not happening, we need to treat that. Do you all understand? So that is one large factor we need to. Now, an egg coming out is not enough. What is the next factor? The tube must get the egg into its fimbrial end. Okay, so there must be ovum pickup. So from there, what does it mean? Any problem affecting the tube will cause infertility. So what is that called? We have ovarian infertility or an ovulation. Then we have tubal infertility. Any factor causing problems in the tube, the pickup, the transport, nurturing of the ovum and the zygote and the embryo. You know that when the first cell forms, right, it divides into a zygote, and then it divides into, builds its own trophoblast, and then it comes down very slowly down the tube. All the while it dividing. It takes 5.5 days for that journey to come down. By the time it comes down to the uterine cavity, it should have a trophoblast and it should be ready for implantation. Right? That 5.5 days journey is important for it to develop, get nurtured, and so therefore the tube inside, the cilia, the muscle, the chemical environment, everything needs to nurture or make sure that the baby grows nicely inside, and slowly the muscle must send it down very slowly. If it comes too fast, then it has not developed the trophoblast to implant. So it won't implant. If it comes down very slowly, if there's a problem with the tube, it will implant in the tube and we have an ectopic. You all understand? So therefore, the tube is an extremely important organ for natural conception. So it's just not a tube. So therefore, it is very important that the tube is normal and it is not affected. Got it? So when we are looking at a history and doing the examination and doing the necessary other investigation, we need to have a look at the tube as well. Okay. Next very large area is the uterus. Okay. There must be a good uterine environment for the baby or the embryo to implant. How does that happen? Now, the egg, when the embryo comes down, 5.5 days, the corpus luteum is producing progesterone, right? And this progesterone acts on the intrauterine environment, the endometrium, and it starts to prepare a place for the baby to implant. It is thought that place is preferential. It doesn't just go into the uterine cavity and, go around and just trying to find some place. There's a preferential place. And apparently there are something called like, those are called pinopods, like sort of large cells that absorb the secretions so that one area is exposed with all the receptors exposed, like mushrooms, right? So they absorb all the secretions in one place, and that one area, the baby can go and implant, right? So it takes about 5.5 days to develop that. So therefore, that is why the journey is extremely important, this 5.5-day journey, for it to come very gradually, perfectly to come and implant. Is that clear? So now anything affecting this intrauterine environment, right? Whether it is the cavity, whether it is the myometrium, whether it is the implantation site, anything can cause infertility as well. So we need to, when we are doing the investigations and the history, we of course need to have a look at the uterus as well. Got it? The next thing, it's very important, right, that the male, right, should have enough sperm. The male should be able to ejaculate it, and the male should be able to ejaculate it inside the vagina. Right? So therefore, sexual intercourse needs to take place, right? And so therefore, we need to find out whether there's a male factor infertility and also whether sexual intercourse is taking place for the woman to conceive. Is that clear? So when you are looking at all the areas of infertility, remember it is very easy because you have to concentrate on ovulation, you have to concentrate on the tube, you have to concentrate on the uterus, and you have to think whether they are having sexual intercourse. Of course, the other things are important, like the general body, if there are problems. In the pelvis, is there a biochemical environment which is disturbing this, like endometriosis? Right? So endometriosis will disturb everything. It will disturb the ovulation, it will disturb the uterus, it will disturb the tubes, right? It will also be toxic to the embryo and the sperm and the ovum. Right? Or you need to understand it may be a general problem like hypothyroidism, right? Where the thyroxine is not enough and that prevents ovulation. Whether it is hyperthyroidism, sometimes that also will affect fertility. Whether it is hyperprolactinemia, when there's more prolactin, ovulation and the whole process will not occur, right? Then diseases which are chronic diseases, all these can affect the whole process, especially ovulation in women, right? So the body in general and the specific sites in general, we need to find out, check, investigate, and if necessary, treatment for infertility. Got it, children? Right? So that is the view, overall view which you need to have about fertility and or infertility. Understood? Right. Then comes, so let's take the specific areas first as to what we are the causes that can have this problem, right? So let's take the commonest thing is ovulation. Okay. So what are the things that causes an ovulation or problems with ovulation? It's very simple. All right. It's just 4 areas, right, which we need to think about. What are these? Problems with the ovary. Okay. So those are ovarian factors, right? What is the second thing? Problems with pituitary, because the pituitary produces FSH and LH, right? And they need to stimulate the ovary to produce follicles, and then LH will cause it to ovulate. Okay. What is the third factor? We have the ovary, we have the pituitary that may be malfunctioning, right? And the third thing is the hypothalamus, right? The hypothalamus may be causing us problems that can cause an ovulation, right? So basically, these are the 3-4 factors which you need to talk about. So if you are going to, first of all, if you are looking at the ovary itself, right? What are the problems? What is the commonest thing that causes an ovulation? Is polycystic ovarian disease, right? So you need to remember that polycystic ovarian syndrome or polycystic ovarian disease can cause problems with ovulation, right? So therefore, I have spoken at length about the polycystic ovarian syndrome. So we are not going to talk about it now. Got it? Right. So there's a separate lecture. Please go and listen to that about the polycystic ovarian syndrome, right? What is the next commonest problem with an ovulation, right? Sometimes, hold on, give me one moment. Right, sorry. Right, sorry. Where were we? No, I lost the track. Yeah. Arya Tilaka, tell me where.
Sir, polycystic ovarian. Yeah.
All right, okay. So one of the commonest things for an ovulation is polycystic ovarian syndrome. Please go and listen to my lecture on I did a comprehensive lecture on polycystic ovarian syndrome and how to treat it even with infertility, right? The second thing is what we call hypogonadotrophic hypogonadism, right? Don't worry too much about the big words. What are the gonadotropes we know about? FSH and LH, right? What is hypogonadotrophy? It's simply because the pituitary is not producing FSH and LH. And therefore, the ovary is not working. That is hypogonadism. Got it? So basically, the pituitary is having problems. What are the things? Where are the things that what can happen to the pituitary? The first thing is if there is a pituitary tumor. Okay. What are the commonest tumors? That any tumor that is happening in the pituitary can cause problem. Especially there can be pituitary adenomas, which can produce prolactin, right? You all know that. And then there are maybe other like craniopharyngiomas. All these pituitary tumors can cause the pituitary not to produce these things, right? What are the other? So those are the pituitary. What is the other thing, right? One is called a Sheehan syndrome. Have you heard about the Sheehan syndrome? When there is a sudden blood loss, sometimes the pituitary can have problems, right? And then the pituitary, you can have a dysfunction of the pituitary. So the pituitary can cause the functions can get reduced in the pituitary, right? The next thing is the tuberculosis can affect pituitary, but we don't. Maybe some time ago when we had a lot of TB, sometimes we used to find that tuberculosis can affect the pituitary, right? However, now it's not very common, but it was there some time ago. So those are the commonest things that can affect the pituitary, right? What are these? At the ovarian level, children, it is PCOS, right? At the pituitary level, these are what? TB, tumors, right? Pituitary adenomas and craniopharyngiomas, tumors, right? and Sheehan syndrome. So those are the ones that there are rare causes that can cause, which you all really don't need to know. There are different Lawrence with there may be, right, Kalman's, all these syndromes are there, right, that can cause or problems in the hypothalamus pituitary axis. But if you know TB, if you know Sheehan's, right, if you know pituitary adenomas, that should be enough for pituitary. What happens? The FSH and the LH is not being produced to stimulate the ovaries, right? Then the hypothalamus. Now, at the hypothalamus level, right, the commonest things that cause anovulation are, number one, things that are coming from above, where the GnRH pulsatory production is reduced. Those are the releasing hormones, because the releasing hormones will stimulate the pituitary. The pituitary will put out the FSH and LH, right? And then go and they will have an influence on the ovary to produce the eggs, right? What is the other cause for hypothalamus? Mainly, these are the things that when the GnRH pulsatile production is disturbed. And these are what? Strenuous exercise in patients who are doing very strenuous exercise, like Olympic athletes, like national level athletes who are always exercising, right? Those, the hypothalamus will downregulate, right? The second, stress, extreme stress, right? For example, it's called, sometimes when the school changes, when women are studying for exams, right? When there are other stresses at work, right? So when there is stress, the hypothalamus will downregulate and will not produce the GnRH, right? So therefore, that anovulation can occur via that as well, right? So that is the other thing that you need to think of. So that is basically problems with the hypothalamus pituitary that does not produce the stimulating factors, which is called hypogonadotrophic, right? The gonadotropes are less, and then there is because of that we have hypogonadism. The ovaries are not working. Is that clear? Right? And the third cause is what? We have hypergonadotrophic hypogonadism. What does that mean? That means initially the ovaries have failed. We have premature ovarian syndrome. Oh, sorry, premature ovarian failure. So the ovary, for some reason, it has either failed or sometimes it can be resistant. These are called resistant ovarian syndrome, where it doesn't really care whether the FSH and LH is coming. It's resistant to FSH and LH. You all understand? Right? So therefore, that is a resistant, and in the ovary has failed, right? And there's premature ovarian failure. Then also what happens is there is no follicle production. Now, what tells the pituitary and the hypothalamus, especially the pituitary, okay, look, I'm not doing anything. So there are certain feedback mechanisms, right, to the hypothalamus pituitary axis. And what are these? It is inhibin. You all would have heard inhibin B, and the other thing is estradiol, right? Estradiol production from the ovary and inhibin, right? Production will tell the pituitary, look, I'm working. Now these are not being produced. No inhibin B and the estradiol is not being produced by the follicles from the cells. So therefore, the pituitary and the hypothalamus thinks, look, these fellows are not doing anything, so they send a lot of FSH and LH. Okay, so the gonadotropes are very high. FSH is high, right? LH is high. Gonadotropes are high, right? So you have hypergonadotrophic. The FSH is very high, but there is hypogonadism because the ovaries are not working. Is that clear, children? Right? So those are the types of anovulation which you need to know and think about, which is easy, right? And so, got it? right? So in summary, we have an evolution due to PCOS, which has its own place because it's quite common, right? Then we have the FSH and LH not coming from above due to the pituitary and the hypothalamic problems, right? And then we have the ovary not doing its way because it is either resistant or failed. And therefore, the FSH and LH is high, but this is not doing its work. So those are resistant ovarian and premature ovarian failure. Is that clear, children? Right? So therefore, we will have to, when we are looking at the ovary, we have to look at all these factors as well. Right? Next, that is everything that you need to know about the ovary. Okay? The next thing is, let's go to the tubes. What are the problems that can affect the tubes? Mainly tubal factor infertility. Mainly it may be compression from outside. You compress it, they can adhesions. What are these? You can have endometriosis. If surgery has been done, then pelvic surgery. Sometimes appendicitis, some anything with abscesses, appendicular abscesses, all those can peritonitis, all these can cause adhesions. What is the negative? Those are surgical adhesions. What is the other thing that can cause problems? For example, the tubal end, if it becomes adhered, the tube still produces a lot of fluid, and normally they go out from the femoral end to the peritoneal cavity. And suddenly, if there are adhesions and then the tube is closed, it swells up like a balloon. And when it swells up, the pressure builds inside, and all that very delicate cilia and the muscle coat, everything gets destroyed or traumatized, right? And therefore, it does not function well. So it can cause hydrosalpinx. Sometimes an infection can go there, and you can have a pyosalpinx, right? So that can also cause infertility. Next thing is pelvic inflammatory disease can cause problems with the tubes, adhesions. The commonest pelvic inflammatory disease that can cause that is chlamydia in most of the West, and we don't have that much. But there are maybe other reasons that other pelvic inflammatory disease that can cause adhesions and changes in the tubes, right? So even fibroids emerging or living in the broad ligament can cause compression, or it can distance the, if they grow between the ovary and the tube and they part, because for the egg pickup, the ovary must, the femoral must be near the ovary, right? If they part and the fibroid in between, and therefore the tube gets stretched over a fibroid, especially broad ligament fibroids, right? Or fibroids on the side, then of course it can also cause infertility due to a physical distancing between the tube and the ovary. Do you all understand? So that also can happen. So those are the things that can happen to the tube. Okay? Right. So now let's get on to the uterine factor. And what are the things that can affect the uterus? Anything living inside the cavity will prevent the implantation. Okay? So if it is a polyp living inside the uterine cavity, it will prevent implantation. If it is a fibroid that is living inside the uterine cavity, it will prevent implantation, right? If it is a fibroid that is near the cavity, either encroaching, pushing, or distorting the cavity, can cause infertility because the implantation will not occur, right? Large fibroids living inside the myometrium, is intramyometrial ones, right? Or may or may not, if there's a large distance between the cavity and then if it is not disturbing the cavity, maybe it might not, but we are not 100% sure as to what sort of influence it has on, especially large ones, it might be influencing or having an influence on the fertility as well. However, it is known that subserosal that are jutting outside does not cause infertility. although very large ones may cause infertility, especially, of course, if they're pushing at the tubes and the ovaries and distorting their distance from each other, they will. But however, if they are purely subseroral or pedunculated, they might not cause infertility, right? If there are uterine anomalies, right? Different types of anomalies with septae, where the tubes are, but the tubal ostia are placed far apart, right? When there are large distortions in the cavity, congenital anomalies, all these can cause infertility in these patients, right? So those are the uterine anomalies that may cause infertility, right? Is that clear? Right. So, sorry, one. Right. So those are the uterine anomalies. The next thing, of course, we have to talk about is they need to be having sexual intercourse at least 2 times a week. So if there's a problem with the sexual orientation, right? If there's a problem with, for example, if the person, if the male is more interested in other males, right? Or if he's not having sexual intercourse, then if there is, if the male is having problems with ejaculation or problems with erection or problems with sexual desire, any problem there, then it can affect the fertility as well. So you need to give a very discreet, very sensitive history from these patients if they're having these problems, right? So those are the things that we need to understand about the chances of things that can go wrong in the fertility. Of course, there are so many things that we cannot in our industry find out, because there are, as I told you, remember, directly about 32-33% of the things is unexplained infertility. It's not because it's unexplained, it's simply because we can't find, or we have because we do not know the functions exactly of the sperm. We do not know the functions of the ovum as well. We do not know, we cannot test any of these as to see whether they are, we cannot test the functions of the tube, right? So those things we cannot really investigate. So therefore, there will be a group that we call unexplained infertility as well. Is that clear? Right? So that is the overall picture that you need to understand about infertility. So this is the overall picture. Next, we move on to what we need to ask these women, right, in different kinds of histories. Okay. So what you have to understand is, what you are basically doing in the history is trying to find out, okay, whether any of these areas are affected and whether we can take that from the history itself, whether this ovary, there is an ovulation, tubes, uterus, sexual activity, and see whether these areas are affected, so that we can discover that from the history, where there may be certain things in the history that will tell us what the problem is. Is that clear? Right. So give me a moment. I need to take a call. I'll just pause this for a moment. Right. Sorry. Now, let's go through. We stopped at history, right? Okay. So now, what do we ask these patients? And what is important that what we ask these patients, right? First of all, we need to speak to both of them. There's no point in talking to the men. We need to talk to them as a couple, right? So it has to be, ideally, it needs to be a quiet room, right? Private room, right? Sometimes these facilities may not be available in our clinics, right? Where sometimes it's a general clinic, right? So it's not a very good environment to take a sexual history and a sexual history for infertility, actually. So we should be providing is a very private, confidential way of talking about these problems, right? So generally we need to ask them about their Okay, who are you all? And especially we need to talk about the age as well, because the age, as you remember, when the age goes up to about 35 years, the natural fecundity falls, the chance of conceiving naturally, right? By 37, it falls a lot. By 40, it's very, very low. And when you go beyond 40, the chance of natural conception becomes small, because the follicles and then other follicles, they are old. The eggs are old as the woman, right? Because or even slightly more, because they happen in intrauterine life, right? And they bring a certain amount of women bring an amount of eggs with their ovaries, and with each cycle it's depleted, right? And also they become old, and therefore when if conception happens, there may be defects, genetic defects in the embryos, and therefore they will not implant or they will miscarry. So therefore, the more the age, the higher the chances of miscarriage, and the less the chance of conception, right? So that is very nice. So that is something that we cannot change. However, there is hope for these women, because now there are assisted reproductive techniques. There are ways in looking at the embryo. There is a chance for donor eggs, right, where you get a younger egg and she can conceive. So therefore, these answers are there. But what you have to understand is, one of the factors that make consent may be the age, right? Then the general factors, okay, are they engaging in sexual intercourse, right? Are there stress factors? Are they fighting, right? Are the other people around them influencing them, right? Are they very stressed at work, right? What is the environment in which they are working, especially for example, so this is the general information, especially for the male partner. Is he exposed to chemicals? Is it is he working in a high temperature zone? Is there irradiation? So those general questions need to be asked from this couple itself, right? What they are doing, right? Is the work stressful? So those may be contributing to infertility as well, right? So that is number one. Next is, let's look at their menstrual history. Now, what does menstruation tell us? Menstruation will tell us whether this woman is ovulating. So if there's a problem with menstruation, if it is not very regular. Now, what is regularity? If there's a gap is between 3 and 5 weeks in between the bleeds, that is normal. It doesn't have to come every 28 days, right? Anything between 3 and 5 weeks in between is normal. So if she's getting that, that is regular menstruation. What does that mean? That means on the other side, when you look at it, yes, they must be ovulating regularly. Okay. If it is, she's not having menstruation like that, if she is having rarer menstruations, right, far apart, right, or not at all for 6, 7 months, 8 months, she's not having a menstruation, right, or she's having lot of irregular bleeding, then probably she is not ovulating very regularly, right? So that is very important. At the same time, it is important to find out about her symptoms during menstruation. Is she having a lot of pain, right? What does that go? Yes. Is this woman having a fibroid in the cavity? Is this woman having endometriosis? This woman had pelvic inflammatory disease, and does she have adhesions, right? So those are things that need to go into your mind. Is this woman having a polyp or a fibroid inside the cavity? Because during the periods, it tries to push it out, whatever, but it's connected to the cavity, so it's not going to go out, but the pain is going to come. Okay. So is this woman having a lot of bleeding, menorrhagia? What can it? Maybe a polyp, maybe a fibroid inside the cavity, maybe a fibroid near the cavity that can cause menorrhagia. Maybe it is adenomyosis. So you all understand? So we have to know about it. Does the woman have premenstrual pain? Commonly, it might be adenomyosis, or most commonly is endometriosis, right? Which can affect the tubes, the ovaries, and the uterine environment, and everything, right? Is this woman having dyspareunia, painful sexual intercourse? Okay, that is around the woman. Then it might also be endometriosis, right? So, but we are talking about menstruation. Is this woman having pain after the menstrual period, which is post-menstrual pain? Okay, is this endometriosis, right? So, is this woman having very rare periods and then prolonged bleeding? Is this PCOS, right? So those are the things that we have to ask and think about menstruation, right? So that is how we pick up the menstrual history. So general information, right, about the male, how they are whether stressful or anything like that. Second, about the menstrual history, right? What is the next thing in the history that you need to ask, right? Any pain syndromes. So pain syndromes are 9. You need to remember. What are these? Especially for endometriosis. Dyspareunia, what does that mean? If the rectovaginal septum and the ovaries, and if there's deep infiltrating endometriosis around the pouch of Douglas, right, in the near the posterior fornices, then sexual intercourse becomes painful. So is this endometriosis that can affect her? Does she have backache? In your mind, what should go? Okay. Is there hydroureter hydronephrosis? So if there's backache, do a ultrasound KUT. Because the ureters might be affected in the lower end and causes hydroureter hydronephrosis and backache, right? Is there menstrual pain? Endometriosis, maybe, right? Or fibroids. Is there pre and post menstrual pain, right? That is bowel openings painful. That is dyschezia. When if there's endometriosis on the bowel or adhesions on the bowel, when it stretches, it becomes painful. When she defecates, the pain goes away. That is dyschezia, right? Is it painful to pass urine? Is it bladder endometriosis? Are there pain going down the legs in certain areas to the thigh, to the knee joint, where the sciatic nerve also goes from behind? Are the nerves involved with endometriosis, right? So those are the things that you need to talk about the pain syndromes in the history. And because one of the causes is endometriosis for infertility. So therefore, you have to ask these questions, right? So this is about then chronic pelvic pain. She always have it. Usually that is either adhesions, thick or endometriosis, right? So then that is about the menstrual history and then the pain history. Obstetric history, what is there? It's important because, okay, did she have a postpartum hemorrhage? And after that, no periods. Okay, is it? She has. Okay, then just what happened to the pregnancy? Were they successful? So then it obviously becomes a secondary infertility, right? Then how did she conceive? Was it with ovulation induction? Were there any special things? Was there in vitro fertilization, right? How did she conceive? So that becomes very important as to how she conceived the previous time, okay? Then in the same history or in the gynecology history, were there any curettages done? Evacuation of the retained products of conception, right? Or dilatation and curettage, was it done? What does that want to click? Is there a problem within the uterine cavity? Very rigorous curettage would mean what? Adhesions inside the uterine cavity. And what is that? So that what is that syndrome? Yes. You can have intrauterine adhesions that can prevent, that can cause painful menstruation as well as infertility, right? Past history of, so we'll go to that. So those are the ones in the obstetric history that we need to know about, okay? Then we go on to surgical history. Were there any surgeries done? If there are any surgeries done, was it fibroids removed? So if was the cavity opened into, if so, the cavity can get distorted and there can be adhesions in the cavity, right? If the myometrium was, the fibroids were removed, then of course what can happen? You can have adhesions due to the surgery for the ovary and the tubes. and that can distort the tubes as well as the ovary. It can get stuck, right? And the normal function might not be there. Were there any surgeries for endometriosis? If it is severe endometriosis, then there'll be, maybe there are endometriomas that will change the chemical environment, that will affect the ovulation, and that will affect the tubes, right? Where the ovum pick up, it's embryotoxic, sperm toxic, ovotoxic, right? The chemical environment will change, adhesions will form, and therefore that can cause problems. So were there any surgeries for endometriosis? Were there any surgeries for other things, for appendix, appendicular abscess, that can cause adhesions and can cause a normal function of the fertility process to get disturbed, right? Were there peritonitis? Were there any laparotomies? All these can cause pelvic adhesions and changes in the tube and the. So anything, any operations on the womb. Was there an adenomyomectomy that can cause distortion, right? And anyway, adenomyosis will also continue to grow, right? So therefore, any surgeries in the tummy can cause infertility. Are the ovaries buried because of that, right? They will have severe pain during ovulation, right? Because buried in adhesions. And that also can cause problems with ovum pickup, right? So those are the ones that you need to ask about the surgeries. Keeping in mind, is the uterus affected? Is the other ovaries affected? Are the tubes affected? Right? So those are the things that you need to keep in mind when you're talking about the surgical history, right? Then, of course, the other things. One moment. Getting continuous calls. Hold on. Sorry, where were we? What did I do? I did menstrual history, right? I did endometriosis. PCOS, I have already spoken about the history, right? You have to know what PCOS is. Please go and see what you need to ask in the history for that. Past surgical history, spoken, right? Right, okay. So the other thing, next thing is you need to ask about the sexual history, right? Are they having regular intercourse? Is the male having problems with sexual? Is she having problems with sexual desire? Is the libido reduced, right? So those are the things that you need to ask in the sexual history to see whether there are any problems there, right? The next is medical history. As remember, I told you, if she is on certain medications, right? Some NSAIDs also, you know, if she's on regular NSAID, that can cause problems with ovulation, right? Is she diabetic? Is she having hypertension? Is she on antipsychotic drugs? Is she on any chronic, is she having chronic medical problems? All that can cause anovulation and problems, right? The next thing is we have to ask her about contraception. Because sometimes they will come and say, okay, I'm not conceiving. They might be having a jadel which they have forgotten. Okay, they may be having a intrauterine contraceptive device which they have forgotten. Okay, sometimes, so therefore you have to talk to them about contraception. Sometimes, if they have been on dipomedroxyprogesterone acetate injections, sometimes it can cause anovulation for some time. So that may be causing her problems, right? Sometimes these intrauterine devices may have caused intrauterine adhesions, may have caused pelvic inflammatory disease, right? These also can cause infertility. So those are the things that you need to ask them about this. So when it's sexual history, medical history, surgical history, social factors, right? All these things must be contraception, all this must be checked in the history. Is that clear, children? Right? So that is the history which you need to ask. And remember, how does the history go along? It flows around ovulation, tubes, uterus, and sexual activity. Okay? So, and of course, there may be other factors like hyperprolactinemia. They may be having they may be still breastfeeding, that can cause anovulation, right? So there may be features of hypothyroidism or hyperthyroidism that also can cause anovulation and infertility. So those are the general things that you need to ask these patients, right? Next is, so are we clear up to this point, right? So next, what we have to understand is how do we examine the female, right? What are the things that we do to examine the female? Now, there are certain things. So what do? We have to look at the ovulation. We have to look at the tubes, look at the uterus, and those are the things that we need to look at, because I will not talk about the male partner today. Got it? Right. So how do we look or investigate the female partner? Number one, first of all, of course, we need to do a general examination. We need to do a abdominal examination, and we need to do a vaginal examination, right? And a speculum examination. That will tell us whether there are any abdominal masses, whether there are any uterosacral nodules, whether there is endometriosis, whether there is adenomyosis, which one can have a retroverted, or endometriosis can have a retroverted fixed uterus. Adenomyosis will give a tender uterus, right? Mobility can be checked. So all that clinically we should be able to check, and we can gain information as to see whether there's something wrong, right? So then, of course, if she is overweight, then we have to advise her to go to a dietitian, or if she's very overweight, we might even ask her to go for bariatric surgery, right? So bariatric surgery will make them lose weight, and then the fertility will be very much enhanced in the patients with bariatric once they start to lose weight. Or if they are underweight, we need to send them to a dietitian and a specialist for nutrition for them to gain weight, because when they are underweight also, an ovulation can occur. Is that clear? So all these, the BMI, general examination, everything, screening for medical problems, all this requires to be done in a patient when you do the examination, right? Okay. Next comes our other part. Okay. Now, what are the things that we want to do, like investigations to find out whether the woman is ovulating? And how do we interpret these results? Right? Remember, I have discussed the history now. So we are talking about the ways in which we find by investigations whether the woman is ovulating. All the old things are gone. We don't do them. We don't do dietitian curettage in the luteal phase to see whether the histology tells us whether it's luteal phase. Okay. We don't do the spin barcade to see whether the cervical mucosa is stretching. We don't do it on glass slides to see whether there is ferning pattern, right? We don't do basal body temperature to see whether the ovulation has caused. So those are all historical things which we don't do. Okay. What do we do, or can we do? Number one, all right, for these investigations, to see whether she's ovulating, one of the ways which we can do it is actually do a transvaginal scan and have a look at the ovary. So if there is an follicle forming, which is about 1.8, 1.9 to 2.1, which means she is forming ovulation follicles. And then after a certain next day, when you do that, it has gone, it has shrunk, and you can see the corpus luteum. So that can tell us, but you need serious scans for that and transvaginal scans. Okay, that is one way. If you don't have the, you can use that. The second thing is, which you can do is, we can do luteal phase progestogen. Now, what does that mean? Mid-luteal phase. What that means is the luteal phase is always constant, 2 weeks, right? So a correct mid-luteal progesterone, right, is where you check for the progesterone 7 days before the menstruation. So if your sample has been taken 7 days before she menstruated, right, which means in the mid-luteal phase, then that is the correct sample and tell us whether she is ovulating, right? So what do we do? Now, if she has different lengths of the cycle, say 3 weeks, 4 weeks, 6 weeks, 7 weeks, then what we have to do actually is to start taking progesterone, blood samples for progesterone, starting from the 3rd week, 21st day. And then we will know only if that is mid-luteal, if she has menstruated on the 28th day. Is that clear? If she does not menstruate, you have to take another sample at 28 days. And if she menstruates at in 1 week, 35 days, then you know that the 28th day sample is actually the mid-luteal sample. You all understand? Right? So you can ask a history to say if she has very regular sort of periods, then of course you can calculate, okay, this is the time you need to do mid-luteal progesterone. Right? So if the mid-luteal is over 30 nanomoles per milliliter, right? Over 30 nanomoles per milliliter, then of course that tells us what? 30 nanomoles per liter, right? And that tells us that she has ovulation. If it is less than that, and if the sample is the correct mid-luteal and she has not, and then probably she has not ovulated much. Do you all understand? Right? So that is checking for ovulation. So you can check it physically, right? And you can check it by a scan, and then you can check it with the mid-luteal progesterone. So those are the two things that you can look for. What are the other things that we can look or check to see how do we interpret these trends? For example, if you do day 3, FSH or LH, how do we interpret that? If the day 3 FSH and LH is more than 10 international units per liter, right? We are looking at a problem, because that would say that the ovary, right, day 3, the ovary is getting highly stimulated, because it should not happen. It should be less than 10, right? And then the gradual FSH-LH rise. However, even on day 3, if the FSH and LH is working over time, right, producing a lot of FSH and LH, we may be looking at a reduced ovarian reserve, because the pituitary is sending, okay, come on, work, and so it might tell us that there's a reduced ovarian reserve. Okay, so that is how you interpret this. So if it is less than 10 international units per liter, then there's a possibility there's a reduced ovarian reserve, and also that these patients may not very well be successful if they try to, even if we try to stimulate ovulation with medication, right? So that is an indicator that there might be a problem. The next thing is, how do we interpret the AMH, anti-Mullerian hormone, right? AMH is a glycoprotein which is produced by the follicles, right? And especially its function is to have a function to produce the male organs, right, in the body, in male. And also it is produced by the follicles, right? And it purely tells us the amount of follicles that are there, right? So ways of looking at the ovarian reserve is looking, either you can count the antral follicles by scan, right, which are visible, or you can do an AMH, anti-Mullerian hormone, right? Anti-Mullerian hormones are produced by the granulosa cells, right? So the more follicles that there are, the more reserve, the higher the anti-Mullerian hormone. So the norm is between 1 and 4, right? If it is less than 1, it tells us that the reserve is low. So there's no timing for it. You can do it at any time. You all understand? You can do the anti-Mullerian hormone at any point in time. So therefore, it tells us whether it's a good way of looking at the ovarian reserve, right? So this is one initiative which we can do, right? So I have spoken to you about what? Mid-luteal progesterone. right? I have spoken about FSH and LH and how it needs to be interpreted. If it is more than 10 interactions per liter, then probably the ovarian reserve is less and the ovaries are not functioning properly, right? I have spoken to you about the AMH. If it is less than 1, the ovarian reserve is low. Between 1 and 4, it's normal, right? Over 4 and 5, there's a possibility there's a lot of follicles producing things. What are these? Polycystic ovaries, right? So that is a bit controversial, but between 1 and 4, we are happy. Then the next thing is testosterone. If the woman is producing a lot of testosterone, then we might be, especially if it is more than 2.5, right? If it is more than 2 nanomoles per liter, there is a possibility that the woman may be having polycystic ovarian syndrome, and if it is very high, then we might be thinking about virilizing tumors, right? Testosterone producing tumors. Normally, it should be less than 2.5 nanomoles per liter, right? So that is how you interpret that. The next thing which you can do is you can look at prolactin. If the prolactin is more than 1,000 interaction units per liter, what should go in our mind? Because especially we do that if there's galactoria, right? And if it is very high, right, then in our minds, what should go on? Is this woman producing prolactin from an adenoma? And where are the adenomas? Pituitary. So therefore, you might need to do further investigations like MRI to see whether the woman is having a large adenoma, which is producing these things, right? Okay. And of course, if she's not sure about rubella, you need to do a rubella test, right, for the investigation to see whether she's immune. And if she's not, you have to ask her to get the rubella immunization. So those are the normally blood tests that we'll perform for these women, right? Of course, if you are suspecting thyroid problems, then you ask them to do the T3, T4, TSH, right? If you are thinking of medical problems, then you of course do the fasting blood sugar. All this you can do if you are suspecting any medical problems at the same time. Is that clear, children? Right? Those are the blood tests that you might want to do for the woman just to find out what is sent, right? So again, if we recap or look at it, right? Ovulation, I told you how to find out. Regular periods, probably ovulation is happening. Okay. Then mid-luteal progesterone over 30, yes, probably the ovulation is happening. Okay. Ovarian reserves, looking at ovarian reserve, 3 tests. Day 3 FSH, day 3 LH, and anti-Mullerian hormone. If the FSH and LH is more than 10, or the anti-Mullerian hormone is less than 1, we are looking at problems, right? The ovaries are not working very well. You all understand? If this is happening, and then what we are doing, if we do FSH, and if the FSH is very high, right? LH is very high, then if there is a possibility it might be what, children? Premature ovarian failure or resistant ovarian syndrome. You all understand? Right? So that is hyper, the hypergonadotropin FSH LH is being produced a lot, right? But the ovaries are not responding. So therefore, you can do the FSH and LH and see whether you can get an idea about that as well. Got it? So those are things that you can do as far as blood tests are concerned for these women. Right? So of course, if you are suspecting polycystic ovarian syndrome, there are other tests which I have spoken to you about in the previous. So these are basically the tests that can be done, right? Next, let's look at what we have to find about. Okay, so that is the ovary. Then of course, we have to do a scan. When you do a transvaginal scan, we will see whether there are cysts in the ovary, whether there's endometriomas, whether there are any other cysts, whether the ovaries are adhered, right? And then we can suspect adhesions, right? And if it is, so we can look at the ovary physically and see if there are problems by doing a, not physically in the sense, by doing an ultrasound scan, right? And polycystic ovary syndrome also, polycystic ovaries also we can diagnose by that. Next, what are the other things we can do? Then we look at the tubes. What are the investigations we do? Go to tube? What you have to know is simply remember, we can only see the shapes of the tubes, right? And there are by scan, what we have to understand. How do we look at the tubes? There's something called hysterosalpingo contrast sonography. High C, right? What do? We don't have it in Sri Lanka, right? Contrast is injected, which is sonolucent. We can see it by scan. So while it's been injected, we do a scan. So when that happens, we see the contrast going into the cavity, and then it goes into the through the tubes, and it falls into the cavity. So we can do a high COSI and find out whether the tubes are patent. So that is one way which we don't use. The second is a hysterosalpingogram. What we do is we take the patient, fix a cannula, and inject the contrast, and then we take X-rays, right? The advantage, it's done only if she has no other symptoms. If she has symptoms of pelvic inflammatory disease, the chance of getting pelvic inflammatory is about 1% in patients after this HST, right? So by doing it, you might cause PID. By PID, you can cause infertility, okay? But HST, if she has no other problems, no additions, no past history of PID, no other symptoms, you can do a hysterosalpingogram. What does it do? It'll show us the inside the cavity, a picture of the inside the cavity, and it can show us polyps or fibroids or distortion of the cavity, and it can show us the inside of the tubes, right? And then if it is swollen up, it is hydrosalpinx, it will show us, and then it will show us whether dye is spilling onto the peritoneal cavity. So that is one way of looking at the tubes. And the other way, of course, is looking at the tube is to do a laparoscopy, right? We do a laparoscopy and we do a dye test by injecting methylene, right? We don't do diagnostic laparoscopies now. So if there's any problem, we treat at the same time, okay? So therefore, when you do that, if there's endometriosis, we treat. If there's adhesions, we release. If there's hydrosalpinx, we try to release the hydrosalpinx and reduce the tubal fluids, right? So those are things we can do surgical wise to look at the tubes, right? But if you want to test the tubes, those are things. And of course, there are other things like tubal cannulation and salpingoscopy, where you can put a small telescope into the tube and you can go through it. And especially, we can cannulate them if there's proximal blocks nearer to the uterus. If the tubes are blocked, sometimes you can cannulate them and sort out the block. That can cause fertility to become better when we cannulate. So those are things that we can do with the tubes. Is that clear, children? Right? And then, of course, what are the things that we do to look at the uterus? Number one, transvaginal scan. We look at the uterus and the cavity. Number two, a 3D scan will give us a better picture. It will tell us the cavity, where the distortions are, whether there are fibroids, polyps, everything it can show. What is the third way of assessing the uterus? Hysteroscopy. You just go in with the hysteroscope and you can assess whether there are any anomalies and if there's a problem with the cavity, right? So those are the things that we can assess the men. And of course, about the sexual problems, you need to ask whether they are having coitus and whether there are any that they are having any sexual activity, that you have to ask separately. Is that clear? Right. Now, so those are the ways which you investigate, and that is you investigate each sphere. Correct? Right. So now let's see what we do about it, right? If there is anovulatory infertility. If the ovaries are buried or if there is no ovulation, then of course you can do certain things for these women to ovulate. Okay. What are these? We can give medication like clomiphene citrate. Right? We can give medications like letrozole. Letrozole is given from the third to the 7th day. And then you do a scan to see whether there's ovulation. Clomiphene citrate is given from the 2nd to the 6th day. Day 2, day 3, day 4, day 5, for 5 days. And then you do a scan to see whether it is whether the eggs are being produced, right? You can give tamoxifen as well. So there are different kinds of medication that you can. If those are not working, we can give FSH. It can be pure FSH. It can be recombinant FSHs, which can be given to stimulate ovulation. So there are different ways to stimulate ovulation by medication. You have to know what are the things that we can give for ovulation. Clomiphene citrate, just check the mechanism. Letrozole, check the mechanism, right? Do some homework. Tamoxifen, we can give, check the mechanism. Then FSH injections can be given for ovulation. So that is how you cause the woman to ovulate. If there's if there's a problem, if there are cysts, then you need to operate and remove the cysts. If there are adhesions, you need to do an adhesiolysis, right? Physically, if they are buried somewhere, you need to get them out, right? And those are the things that can cause an increase in ovulation, right? Then there is ovarian drilling. Stephen Leonthal in 1930 something, right, found out that in polycystic ovaries, if we reduce the amount of tissue by doing a wedge resection, ovulation occurs in polycystic ovarian syndrome patients. The reason probably it was found that because the ovarian stroma is producing a lot of androgens, right, and inhibiting the local ovulation, and therefore when you reduce it, right, it will cause ovulation and the women start to get pregnant. But however, it's very traumatic because you do it by laparotomy and then you cut it. That causes adhesions, reduction in the ovarian reserve, right, and pelvic pain and all that. So that was abandoned. But however, later on it was found, yes, you can do the do thing by doing a drilling. You put the monopolar inside and then you heat it up a bit. That causes a bit of destruction of the ovarian tissue. So minimum destruction can cause ovulation. It gives the same results. 4 points, right? 40 watts, 4 seconds, 4 millimeters in depth. And that causes ovulation. It's good in a way if you don't want to give them medication, or for very resistant, if it's resistant to clomiphene citrate or letrozole, then you can try ovarian drilling. And it doesn't cause hyperstimulation, because any medication, the biggest problem is hyperstimulation, and you can cause multiple pregnancies, right? This medication. So therefore, it doesn't cause this. So ovarian drilling is a way of causing ovulation. Medication, that is letrozole, clomiphene citrate, tamoxifen, can produce ovulation. FSH injections can cause ovulation, right? So those are the ways in which you can get the woman to ovulate. Okay, right. So that is about ovulation. Next, what do we do about the tubes for these women? If the tubes there are adhesions, you have to do a laparoscopy and do an adhesiolysis, right? If there's hydrosalpinx, you have to remove the part where it is adhered, release the fimbrial end and cause the fluid to go out, and hopefully it will become normal. Most of the time it does not, but can be. If the tubes have been cut in a surgery, or if the woman was already having a sterilization, right, then we can do tubal surgery, which we do very rarely because it requires expertise. It needs to be joined together. The best way to do a tubal surgery is if the amount of destruction is very small, especially by a clip. So if ligation or the sterilization has happened with a clip, which only destroys about few millimeters of the vehicle, a clip has been applied and that is sterilization, then of course we can do a laparoscopic reanastomosis. The success rate is about 60%. However, the way which in Sri Lanka we have been doing tubal ligations is you lift it up and cut most of the thing. So basically, a large portion of the tube or the femoral end is missing. So tubal surgery has become almost redundant now, given those destruction of these tubes. However, if it is just a clip that has been placed across, then if you have the expertise, then of course we can join the tubes and anastomose tubes by doing a laparoscopy. So tubal surgeries have gone out, right? Mainly in Sri Lanka because of the big destruction of the tube. So even if you join them, it won't work. But of course, if the woman wants natural conception, doesn't want IVF, and she wants the tubes repaired, and it has been a clip that has been applied, yes, you can, if you have the expertise. Laparoscopy is better than laparotomy to join the tubes, yes. Then that is tubal surgery, right? Adhesions you need to remove, right? Then next comes what? The uterus. If there is a fibroid inside the uterus, you do a transcervical resection of the fibroid if it is amenable to resection. If most of it is inside the cavity, you can do a transcervical resection of the fibroid. If it is not amenable to, if there's a polyp, you do a transcervical resection of the polyp. If there is a fibroid encroaching on the cavity, you do a myomectomy. It can be open or laparoscopy, right? If there are multiple fibroids, it's best to do by laparotomy. If there are certain, usually less than 6 fibroids, and they should be mapped, then you can do laparoscopic myomectomy, right? Then if there are broad ligament fibroids, you remove. If there's adenomyosis, you can do an adenomyomectomy, but that needs an expert to do it properly. So you reduce the amount of adenomyotic tissue, and that can cause an increase in fertility, right? So those are the things that you do on the uterus. If there is anomaly, you may be able to correct it. If there's a septum, you may have to resect it. You have to do a resection of the septum, transcervical resection of the septum, right? So that you can do all these surgeries to correct the uterine anomaly. So these are the ways in which you manage uterine problems. If there's a septum in the vagina, you can do a resection of the septums. If you can do sometimes the lower part of there are anomalies of the vagina, you can correct them, because if the lower part of the vagina is missing, you can reconstruct that part, right? So there's other things that you can do to enhance fertility, right? Is that clear, children? Right? So therefore, now I have overall spoken to you about what? The general understanding as to how to manage female infertility. Okay, right? So I think that covers most of the things that I wanted to tell you all, right? So of course, what is this unexplained infertility? You have to understand, what do? We can try and do no reason found, no tubal factors, no uterine factors, she's ovulating, everything, but no babies, right? Because there are so many things that we do not know about the quality of the womb, the inside of the tubes, right? The mechanisms happening, the implantation mechanism, we do not know and we cannot find out. So therefore, it's unexplained, right? So those, of course, you can try ovulation induction, right? Then you can try IVF with embryo transfer. So those are things that you have to go for if there is unexplained infertility, right? So that is how you treat those. So then the other most important thing is endometriosis. Endometriosis-related infertility, right, is because the chemical environment changes, adhesions forms, right? And therefore, you can have different kinds of endometriosis. So you need to treat this endometriosis properly, right? Like excision of deep infiltrating, the cystectomies, adhesiolysis, right? All these, and then treat endometriosis so that the fertility will be enhanced, right? So this is a general overview of female infertility, which you need to understand as medical students. Clear? Right? So any questions, children? I'll take questions for about 5 minutes. It's almost 11 o'clock. Anything you want to know? Feeling sleepy? Not a single animal today. Very good. Right.
So, excuse me, sir.
Yeah. Go on.
So the investigations that we do for tubal infertility, sir, just one would be enough to confirm, or do we need multiple investigations?
Sorry, I didn't understand the question. Go on.
We usually do high COSI or HSG or appendicitis for tubal infertility. So just one would confirm any tubal infertility, or should we do multiple tests? Sir?
It's like this. Hycosi we don't have. Okay. So that should, the only problem with the hycosi and HSG is that you can introduce infection. So you need to give an antibiotic cover. If all these two fail, those are reserved for patients who have no other problems, no dyspareunia, OS are normal, no tubal adhesions, no past surgery, all that. For asymptomatic patients, we just want to test a tubal patency, HSG is good. Hycosi we don't have now, so right? Do you understand? But that needs to be done under antibiotic cover because infections can be pushed in. So you need to give azithromycin 1 gram if you are doing it. You have to give antibiotic. If any of these tests demonstrate that there is tubal patency, that's more than enough. However, if you are suspecting anything more than anything else, right? Like endometriosis or anything else, of course, it's better to do a laparoscopy and diagnosis. Right? And at the same time, you can treat any problems that you encounter and diagnose because you are looking at the fimbrial end and you are looking at everything from inside. However, if the HSG fails, right, and or it does not demonstrate tubal patency, of course, you have to go for a laparoscopy and dye test to see whether the tubes are patent. You all understand? And if you meet one of the options there is, including hysteroscopy, is that you can do proximal tubal cannulation. If the proximal end, the part that connects to the uterus, if it is blocked during a period, you can do a cannulation either from above, but it's easier to be done hysteroscopically where you can cannulate. And sometimes that will take off the block and that will enhance fertility. Okay, so those are things which you can do for that. Does that answer your question?
Yes, sir. Thank you, sir.
Right, okay.
Excuse me, sir.
Yes.
So what can we do for intrauterine adhesions? Let's say from a previous dilation and curettage?
Right. If there are intrauterine adhesions, now it's very hard for us to diagnose that by ultrasound scan. You can, because the endometrium is very vague, right? And you might not see that. The second thing is she can have a bit of pain, but she has no bleeding as such, right? And then in the history, if there is a dilatation and curettage or any form of injury, then you can suspect uterine adhesions. So what we need to do is to do a hysteroscopy, and the pressure from the water or the normal saline will itself start to reduce the adhesions. And then with scissor, we have to cut off all the adhesions, and you make sure that there is a cavity. After that, you need to put in a copper intrauterine contraceptive device to physically keep the walls apart, because adhesions form when there are two raw surfaces. So when you cut adhesion, there is a raw surface on this side and a raw surface there. And if you don't keep a IUCD inside, then it will go back again. So you are back to the same problem. So once you do that and you physically put something, the walls are apart. And then you need to grow the endometrium. So therefore, you have to give high doses of estrogen, pure estrogen by tablets, usually 4 milligrams a day. That is very high dose, okay? 2 milligrams in the morning for at least 28 days or maybe more, right? Or 6 weeks or 8 weeks, right? That will cause the endometrium to grow because you are stimulating it with high doses of estrogen. So that is what you do for these problems if we suspect intrauterine adhesions, right? Does that answer your question?
Yes, sir. Thank you.
Okay. Any other questions? Chat has woken up. Right, okay. Any other questions? Okay, so today, tomorrow I'm operating. I think there's a very long surgery, right? So we'll stop for today. In the middle of the week, I will try to do male infertility. Okay, depends on my schedule. Then the third will be unexplained. The fourth will be about assisted reproductive techniques. That should cover the complete infertility. The two other things I have covered, endometriosis that is related to infertility and PCOS, right? So that is basically 6 lectures will cover infertility completely for you. Okay. Okay then. Good night.
Thank you, sir. Good night, sir.
Good night.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you.